Thanks to Alexandra Health 2.0 for giving us the opportunity and the platform to discuss on accessible healthcare and types of healthcare mainly, and how we are going to make sure that those healthcare achieve a standard level and able to access by those marginalized community. So we're going to start with a bit of introduction from each of us on our demographic background and also the healthcare system based on our subject matter expert. Then we'll go from there. Is it okay, Francis?
That's absolutely okay with me.
I'll pass it to you first.
Okay, I'm originally from Nigeria. I was born and bred there, and after that, I went to Russia to study medicine, and I'm practicing medicine in the Netherlands right now. Talking about my background from Nigeria, the accessibility to healthcare is very, very, very poor. And what do I mean by that? You see, Nigeria has a population of about 160 million people, and the accessibility to healthcare is just about maybe 1 or 2% of the population. That is very, very, very poor. And especially in the rural areas where they have a lot of contaminable diseases and mental health, which is my passion. So my worry right now is that people in the rural areas don't have enough access to mental health care, and that makes me, that is something which is very, very worrisome.
That's great. So looking into your perspective, what are the common accessible healthcare that provided for your community in general?
The common accessible healthcare accessible to my community in general is community help from families and neighbors from the community itself. We don't really have any organized government accessibility to health, which is very troublesome for a country like Nigeria, where I come from. I'll give you an example. I probably will talk about this later. The churches and the traditional medicine is the most accessible way to mental health care and other health care in Nigeria, where I come from.
Okay. So since we talk about the health service, we have been transforming in the whole world paradigm of shift of healthcare from conventional medicine, traditional medicine, up to primary care during the early 1900s, up to secondary care during the military war on World War II that time. And we are going towards precision medicine, minimal invasive medicine, and until now, we are actually going to preventive medicine. So looking at this kind of paradigm, going back to your context, is Africa having a healthcare system that actually enable the community to access the evidence-based medicine?
Oh, wow, that's a very, very good question. Unfortunately, my answer to that question right now, right here, is no. And the reason for that is all because of finances. Finances are, I mean, if you look at the economic impact Nigeria, Africa should be having, it's quite a rich continent, especially talking from the country where I am from. But the money that has been allocated to health officially is large, but it doesn't really get to the people who really need it. That's the point.
So just to further elaborate, does Africa currently provide a hospital that is having evidence-based medicine that is managed by their government?
That's correct. Again, like I said, it's managed by the government. You see, the point is the corruption is very high.
Okay.
And that makes it difficult to the common man to get accessibility to health.
To the community that is very much marginalized. So the capacity might not be enough to cater for the requirement of the community. Hence, the only accessible healthcare you can go will be the traditional medication that you're talking about, the voodoos and etc. So I'll be explaining a bit of what the healthcare system that we have in Malaysia. So Malaysia is currently a developing country, and we aim to have the standard requirement for a developed country by the year of 2030. We have a lot of reformation. We have a change in government, bipartisan towards a new reform government system on the recent past 1 year. At this moment, our healthcare is actually at a dichotomous, we call it two-tier system, where the major health initiative was started since the colonial region, when the British came over. It actually came from financing mainly by the government. So this system has been continuing for the early 40 years of this independence, where government agencies, the Ministry of Health, is the healthcare provider for the community. Until the late 1980s, where they released a regulation called Private Healthcare Act to encourage private sector to boom up and to help out the government side to provide healthcare services. So at this moment, we are still doing these two systems, and the financing system for these two evidence-based medicine was still tax-based for government system and out-of-pocket or private insurance for the private setting. So for a private setting, the insurance industries from Prudential, from US, UK, all of these insurance companies came in during the early of 1990s. For the past 20 years, they have been booming, having recognition, leading an industry of private healthcare that is actually the leading private industry to increase the paradigm shift and bring in technology that is required to facilitate the capacity and to help out those that is capable to go into the private insurance system. So however, this kind of system is actually not really being penetrated properly into my side of area. So I'm from Penang. I'm born in Penang. Penang is actually an island of peninsula of Malaysia. And Malaysia consists of 3 continents: Peninsula Malaysia, Sabah, Sarawak, and it used to be Singapore. So Singapore left the part of Federation of Malaysia, but Sarawak and Sabah continues to stay on. So what happened is, when we talk about my country, we remember about Petronas, the oil and gas company. But 80% of the oil was rigged from the state of Sarawak towards the GDP and revenue of the country or for development. However, the royalty that we receive is about 2%, which is very, very low. In this kind of system, what you see is the disadvantage of what you call tax-based or the conventional ministry run system, where the funds are only decided by few stakeholders. Instead, it's not being an independent fund. So what happened is, when you're practicing this kind of system, and when my region at this moment in Sarawak, when they do not have a lot of political influence in terms of the parliament control and the cabinet, when you lost the input of power, you do not govern the ability to get more finance towards your region. The good thing is, for the past 10 years, during the political shift towards democratic, Sarawak plays a very significant role. They call them the king player. As they required more support from the government of the Borneo Island, they actually look towards the needs of the community, and more funding actually funded towards this region. Even saying so, the capital expenditure that is required to expand the services for my region are still not at the standard par of requirement for any emergency medicine. We know emergency medicine, as according to AHA, 2 main things. One is the heart, one is the brain. If you have a heart attack, you need to go, the standard treatment will be going for a PCI within 90 minutes or less than 4 hours. That's your golden period. But to connect the whole Sarawak from the first major city to another city where I'm staying, it takes about 18 hours. 18 hours by land.
PCI?
Yes.
Wow.
So imagine if I have any patient that have a heart attack, when they call me when I was in Kuching to refer a case, I can only pray for them. That's the reason when your system is so centralized, and when your area is not being taken into consideration and being marginalized.
What do you mean when you say centralized? What do you mean by that?
Means the portfolio of the portfolio of the healthcare agendas is the authority on the regulation is actually being centralized at the federal level.
Okay.
And the federal level, I mean, it was in KL. What happened is the decision when they made was not being communicated with the stakeholders. Because when you make a decision in the federal level, in the whole country level, it might affect your marginalized community, especially on fundings. So the thing is, because we are separated from Southeast Asia Sea, there's a big sea that separates both of them. It's actually basically an island. It's not possible for the peninsula to understand what is the requirement and the basic needs in the Borneo Island. So if you look into that kind of condition, the only way for us to make changes is where the private sector step up. So what my company did is we actually built up 4 major big centers in all the major towns and cities. So 4 years ago, when I started the project in MIRI, we actually built the first cath lab, and the whole building cost around 80 million ringgit Malaysia, which is about $25 million US.
And if I may ask, how did you get that funded?
We actually are a group of entrepreneurs. So businessmen came in to solve the problem for the government.
Okay.
So we take over in terms that we come out with the capital expenditure, we build out a cath lab, we build out requirement for manpower, and we find a cardiologist who is the state director for that state to come and join us to help us in the community, because our aim is to provide the service first. Once this service is being provided and being accredited, then the next issue comes, because I'm going to have a lot of people that knows that we have the service, especially in emergency PCI, but unable to afford it.
You have the services, but they cannot afford it.
Yes. For example, we call it B40 groups. People with very hardcore poor income, people from district to come over here, they require to use boats or even the regional people. So this group of community, when they come over, the only service that they can access is the alternative service, which is the government-governed service. And when this government-governed service do not have the basic emergency requirement of the city that you have, or they require to transport you to our central service by helipad, it will take a lot of cost, it will delay a lot of time, and we might lose a lot of lives. So what we did during COVID period last year is the government have an initiative to have a public-private partnership program. And this program actually provide funds to private sector to identify the service, the gap service that local community required, and they asked for our proposal on what type of service you wanted to be funded.
So if I get you, it's from up, I mean, you have a centralized system, the government, and it goes down, right?
Correct.
So when the private companies came in, they started from the grassroots. Is that correct? However, the problem is the people who are needing the services for PCI, myocardial infarction, for example, they could not get access to the service you are providing. Is that correct?
Correct.
So what I hear you saying right now is you have the services, you have the product, you have the patients, but you cannot connect them together.
You cannot connect in terms of finance. In terms of finance component. Okay. Because you look into what other countries are doing is people, when the patient goes to see the doctors, they will not concern about out-of-pocket money or finance, because your only mission is to save the person's life, not to think about other things else. So what happened is our facility, we look beyond our resources. With the funding that we have, it's actually enough only for about 5% to be saved for that 6 months life. So we changed the concept of payment method from the traditional insurance retrospective payment method based on fee for service. We actually go a different method of approach where we go towards a prospective service.
Wow.
So we are given, for example, 200,000.
200,000 what?
200,000 Malaysia ringgit.
Okay, and that's about how much dollars?
That's all for you. You need to find a way how much people you want to save. So we engage with our stakeholders. Three main stakeholders that we need to deal with. The first one is the hospital.
Yeah.
The second one is our doctor, who is our partners because they are in private settings. The third one is the suppliers. So what I did is I talked to Medtronics.
If I may interrupt, if you just want to collect 200,000 Malaysian money, how much dollars is that in Europe? Just to get an idea.
Europe will be around, divided by 4, maybe around 50,000.
50,000. Okay, just to have an idea. Okay.
Maybe less than that, about 50 plus to 50,000.
All right.
So what happened is, in order to make things work, in order to scale up more people to be able to cover it for this community group, so we engaged to these three stakeholders, and one of it was actually the supplier. So we talked to Medtronics and asked them whether they can participate in this project and this program to save the community lives, and they agreed to give us at cost price, which is around 3,000 ringgit Malaysia. So from conventional, if we go with the private setting on insurance funding, it will go up to 17,000 to 20,000 for one stent. One stent to open up a life-saving procedure. But we managed to reduce by 50% from this approach. And we managed to scale up the people that we saved from initially budgeted at 5% to increase to 20%.
Wow.
So I think it's not about, it's much easier if the mindset of an organization, especially a private organization, is just purely to earn an income. You might not want to do all this effort. Because since the government is giving you a 200,000, I might as well just do for 5% as budgeted.
Yeah, correct.
There's no need to go and negotiate with your stakeholders and come out with so many solutions in order to scale up the economy. But our intention and the mission of our medical center was how to leverage on top of this fund that we have and to penetrate the service to as much emergency required people as possible. So these are some of the changes and leverage on our local community setting. So going back to you, Francis, do you see Nigeria having any reformation changes or any developmental changes to go towards a standard healthcare?
Yeah, I do. I'm optimistic, cautiously optimistic. I was in Nigeria last year and I visited a medical conference where there was a lot of presentation about changing and introducing a new health insurance system. And so that is the first time that something like this has been spoken about in a medical conference. So that is, there is a ray light of hope. So what I believe right now is the community is basically who the community takes care of its people. I'll give a simple example. Appendicitis, to treat an appendicitis in a rural area where I was born is $400. But you tell me that village farmer, how much does he earn a day? Maybe $1. So it's all left to people like myself. I'm a community builder myself to generate the funds. How do we do that? We go to churches, we go to school to generate the funds, and that's how we do it right now. So it's a pity, I think so, because it's all been left to you are on your own. So when I hear that Nigeria is a developing country and Malaysia is a developing country, I say, oh boy, you are much further than we are in Nigeria, which is a pity for now. Listening to my colleagues talking about introducing a health insurance system in Nigeria was very positive to hear about it. It's not, you are talking about it, it's not about the implementation.
So very good to know from Dr. Francis that Nigeria is going towards an insurance system. Then to make sure that it's actually basically sustainable for your healthcare. Do you know more details on how the insurance system will be implemented?
I do not know the details. Globally, it's about it's a two system. You have the private sector and you have the public sector. Yeah, and the government is ready to subsidize about 60% of the health insurance, and the other 40% will be from the private sector. And how that is going to work out, I really don't know. But I know there's a lot of awareness going on right now in Nigeria that we need a lot of private people like myself and colleagues here who can help out.
Great. So just to share further, I think Malaysia is also gearing towards the last 10 years to achieve a developed country.
Oh, wow.
Where we started a new reform on white paper agenda. Last year, our Minister of Health, Dr. Zaliha, she actually presented in the Parliament saying that we are going to go towards a 4-pillar to increase penetration and sharing of resources among the private and government setting of provider. So one of the things that they did is they wanted to restructure the role of the Ministry of Health. Instead, being a healthcare provider, they are going to release the role of healthcare provider and let the private and government be more competitive.
Yep.
So I personally believe that only through entrepreneurship, business mindset, being more competitive, being more responsive, only that way that we can actually find solutions for a lot of conflicts and challenges that we are facing. So that's the direction they're facing, they are getting away. But going towards that, we are going to face a lot of resistance and challenges, especially from our poverty group. So in order to cover every single one of them, we are going to look into insurance system, a social employment insurance system, where this financing system is going to separate from the Ministry of Health, but is managed by the Ministry of Finance. And this Ministry of Finance, they are going to take over the procurement job for certain government-sponsored hospital while they are competing with the private-sponsored center. And at the same time, they are going to have funds that are more independent, that are not controlled by only few stakeholders, especially the politicians. They are going to make it to be accountable by the parliament. So when these funds, for example, they fix around 5% of GDP to be directed towards this fund, and the Ministry of Finance will have a team to control, to be the payer, to allocate funds for reimbursement back for the services.
Are you saying 5% of the GDP of Malaysia goes to healthcare?
Yeah, at this moment we are doing 4.1%.
Well, that's
tax collectible, not GDP, sorry, tax collectible.
Okay, all right, okay. And so, I mean, you are doing a very, very good job, very, very commendable. I think probably we need to share.
Yeah, we can share more.
Absolutely. What I'm just thinking right now, I'm thinking, what is the best way I could reach those? What is the best way I could reach my community who are not having that care right now? Because it's like I said, it's like now you are on your own.
Yes.
Which is really sad.
I think this is a concept of pay out of pocket, and this is the transition of paradigm. Malaysia, 20, 30 years ago, majority of them still pay out of pocket. In Sarawak, 70% of my market is cash paying market. It's pay out of pocket for private insurance, for private practice. So why is it so different compared to a developed country like UK or even Australia? Mainly is the mindset, and the system is not there.
Mindset of who?
The mindset of the government.
Mindset of the government. You want
and
to
the community, whether or not they can accept to be more independent, to be more competitive, to be aware of their own health. I give an example. For example, 30 years already that the Malaysian government has been introducing private insurance. However, this private insurance mindset has not been penetrated to the native component of our Sarawak region. You can say in terms of education accessibility, it's not at par with the peninsula. And you can say the infrastructure, the road is not there to deliver the information. So the agents cannot be telling them what is the importance of private insurance. Even they have that kind of knowledge about the importance of private insurance, they might not want to actually buy it at a very cheap cost, which is about 5% of their minimal salary. 5% of their minimum salary, you can secure your healthcare, but they believe that this is the responsibility of the government.
Yeah, actually, your health is not as, no, this is how I see it. Your health is not the responsibility of the government. Your health is your own responsibility. So if you are dependent on the government to save you, you will drown. I do also believe that the government is there to help you in some way. Yesterday, we were talking about AI and precision medicine. I mean, I appreciate that, but I'm thinking, oh, guy, what are you guys talking about? AI and precision. The farmer in the village just doesn't know about AI. How do I explain that to him? How do I explain that to her?
Correct.
And somebody was talking about climate change. Say, what are you talking about?
Yes. I do agree with you, Francis. We are saying that AI, which is the latest trend, precision medicine, which is the standard of care that we are looking into at the world level, global level. But you can see even a simple, accessible, basic healthcare. We talk about diabetes care, hypertension medication, primary care. They are not even available in certain areas as what is your area. So how are we going to go up to that level, which is the standard of care that WHO are looking into it? It's actually a very good question. To me, I personally believe that somebody need to step up first.
Who is going to be that somebody?
That somebody is more or less, a lot of time, that somebody, the risk taker, is going to be the businessman, the entrepreneur. I give you an example. In my setting, as a model, our organization saw the gap. And we are willing to take the risk, come out with the money. So we built up the facility that required to fulfill that community. For example, if your community, the basic need may be in terms of connectivity, early identification, you might want to solve whatever issue that you have the highest to reduce it step by step. So you might want a primary care group of doctors to come out and build up primary care centers that can access more information.
To be fair, there are a lot of GPs who are having private practices. Now, I know a GP myself who works in very, very distant areas where there's no accessibility at all. 80% of his work is just charity work. However, that charity work has got to be sustainable.
Correct.
And so what does he do? And credits to him, he makes friends with the local politicians. Because the local politicians decide, and we are talking about mindset, right? How do you change the mindset of a politician? Do you know that?
Mindset of politician basically depends on whether the leaders wanted to grow. Sometimes they will face pressure from the community because healthcare is a basic pillar and the basic needs of life. So it's not just the mindset requirement by the politician. Sometimes the community will pressure them to go towards a better standard of care, and they will use it to politicize their agenda to gain more power. But by the end of the day, if you do not have the power behind in terms of regulation changes, it's very difficult to move forward. But still, you can influence them to change. That's why the key thing that what I want to add on, when you are saying a lot of primary care are doing community work, and whether or not it's sustainable for a long-term period. I give you an example on my organization. I have an agency that is by the government, different industry, different ministry. It's under the Ministry of Women and Health. Their idea was to promote early development and care for the woman and also the family. So what I did is I have a 3D mammogram, the latest one. So, but the cost might be high. So I use the first principle by leveraging on their program and provide the service for free. Free in terms that the community doesn't need to pay me. I just need to get the volume and claim from the other ministry. That's one of the part. You might be able to claim from WHO or even the Gates family. That's one of the part. Second part is the scale of economies. Every operation in terms of business mindset, we will always have a threshold value in terms of operation costs. As long as we are able to reduce the profit margin in terms of prospective measurement, pool fund measurement, you are able to identify how much patient you need in order to break the cost. So for example, my setting, we actually reduce it to 30% profit margin in order to scale up more people to be able to access the M40 or the middle class people to be able to access emergency medicine. So on top of that, regarding technology, that what you are saying, precision medicine.
Precision medicine, yes.
I believe that once you're able to reach that stage in terms of entrepreneur, the next one is to bring in the hope of standard care. Because precision medicine and AI, the reason why we need standard care is we want to have a good outcome for our patient. And when you bring out all this technology, by the end of the day, what you want to do is, when you have a private setting, we wanted to scale up the market to let our regional country, regional people to be able to access a quality standard of care, so that the regional market will expand the cake, and that cake is able to cover or leverage the basic operation costs for our local setting to sustain the operation. So that's the direction that we are going towards, and we welcome a lot of people to come into our region so that we can increase our medical tourism percentage from currently at 5.2%. We hopefully in another 4 years we can increase up to 30% so that we can sustain it for oncology medicine for our local setting.
When you say you encourage a lot of people, what do you mean by people?
Sorry, excuse me.
When you say you encourage a lot of people?
We're encouraging the regional community, for example, people from Brunei. Brunei to our area is only 1 hour. Brunei to Malaysia exchange rate is 3.4 currently. So by building up quality healthcare and ensure it's at a quality standard to give reassurance to the community, we can actually provide a similar service with 3 times lesser the price. And we can actually leverage out, our whole aim was to leverage out our operation costs only, so that we can actually ensure that our service is sustainable and be able to bring in the facility that is required. For example, we are looking into cancer services, so that our community doesn't require to travel 18 hours to get a consultation.
I agree,
Yeah, I think we are gearing towards the next.
Yeah, absolutely. We have about 10 minutes more. So thank you for this very, very insightful conversation that we have been having together. We do, in fact, need to connect more. And I was just wondering if there's anybody in the room who may have some questions to ask about the both of us, and we can share our ideas, how we think about reaching the unaccessible population in the health space.
Accessible, especially for a long distance area. I think we are talking about African countries, we are talking about Southeast Asia, developing countries. Whether or not a district region will be benefiting towards technology to access, to deliver healthcare. We look into the whole perspective of the input of the service, which is the facility. Even we look at the context of drones, what we are facing now is the connectivity, the communication pillar that are supposed to build on that region, and it's not being built. So, and because of certain facility limitation, a lot of service cannot be built up or be provided to be accessed, even though we want to use the latest technology such as AI or virtual reality to access this and provide free information to the district region and tell them that maybe you need to come in earlier so that we can actually treat you. Or we can actually deliver medication towards your house or much easier. I think basic infrastructure that a lot of marginalized community are facing connectivity in the form of transportation and also communication. I'm not sure about how African country is.
That's a very, very interesting question. I don't have so much idea about it. I just want to bring a practical point. You know, Sunday morning, Friday afternoon, that's the best time to get connectivity with the population. You know why? Friday afternoon is when the people, when patients, the local population go to the mosque, and Sunday morning they go to the church. So what happens now? That is the initiative I'm trying to build on. Is I connect with a couple of my GP fellows, and I told them Sunday morning go to this church or that church and that church and give a talk, so the people can come to, because that is the best time you can reach them, and probably also give some education and preventive medicine. That's what I think. So, for me, I mean, how do I say it? AI medicine and precision medicine, as good as it sounds, is one black box for now for Africa. I just want to start from the grassroots. When I get here, and not disregarding AI medicine, I think AI and precision medicine, I think we'll get there. I just need to get it. I need to get in contact with the patients who need it. And so we are setting up a lot of tents. The more churches, the better.
Yes, yes. I do agree with you in marketing perspective. What we are mentioning now here is the words of mouth.
Words of mouth, absolutely.
The words of mouth is the best way of delivering information. So I think the solution that, especially in underdeveloped country, we do not have resources, time. We still can do a lot of things. Like what you say is deliver preventive medicines, health promotions, early warning signs, at least awareness. So I think the key point here is, as human wanted to develop, as the intention is there to develop, we will find a way to overcome the challenges that we have and find the resources that is required.
I mean, you are doing an exemplary work. What you are doing in Malaysia, which is by definition a developing country, is really, really good. I mean, I wish Africa, let me be specific, Nigeria could be this far. However, I am cautiously optimistic about the way we are going right now. This year there was a presidential election, and one of the main criteria that they made is all about healthcare, 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 healthcare.
Yeah. Yeah, I do agree with you. But Malaysia, in a whole collective country point of view, the Peninsular Malaysia is actually very developed. Some of the facilities, they even have robotic Da Vinci, they have AI control, actually at par with Singapore and even the world. It's just that on my part of work that I'm doing and I'm contributing, it's still not being accessible. The only thing is, sometimes you might need to look into a business perspective.
Yep.
Because entrepreneurs, they bring in the fundings.
Yep, true.
They might be able to push things through, and when they're able to see opportunity, programs might be able to be funded. So, for example, if you're looking into my current area, Sarawak itself, it's actually at the Borneo Island, and there's a transmigration of capital from Indonesia. So Indonesia currently has the highest GDP in Southeast Asia, and Jakarta is moving towards that island.
Wow.
So it's going to have a lot of entrepreneurs looking into opportunity in terms of development, growth, and profits. So at this moment, you can actually scale up your economies and deliver whatever ideas that you want. Because if you look into healthcare in terms of purely in your prospect as a welfare equity, it might not be interested with your government. But if you look it into and business opportunity mindset, you might able to find out certain groups that able to fund your programs. And
yeah, that's exactly the point. Is the corruption.
Yeah. Corruption actually spoils the policy, and it actually affects a lot of direct foreign investors. So that's why I say the input will always from the power first. Power, autonomy, regulation, then the finance, resources, and the structural changes resources, such as manpower and talents. So if your current government cannot listen, then you go to the opposition. Simple as that. You let the opposition fit them with the idea, the opposition will leverage on it to go against the current government. By the end of the day, these are all political changes, but you still require power to regulate. And the thing is, don't give up.
Yeah, absolutely not. Like I said, I'm cautiously optimistic. We have just about 4 minutes more.
4 minutes.
Probably, if there's someone in the room who has some questions, could be any questions about our personal experiences, could share, please.
Actually, you have mentioned one of the most important points, which when you spoke about the insurance, health insurance in the health services and the health care. And I don't think that with the time passing that any proper health services can be offered to the public without a proper insurance.
Yep.
I can summarize for you, one of the best examples in the UAE system here, which is one of the best actually, and in the UAE here, every individual living in UAE is health insured, starting from the laborers up to the managers and CEOs and the top of the rank. So the insurance itself is shared between the government as well as the private field. Anybody who's employed in any of the companies, the company is obligatory. If she wishes or not, she should do the insurance for this guy, depending on his rank. Whether he is, how his grade is A, B, or C, or D, then he will get his insurance. When we come to the level of the laborers who are the majority of the expats who are living in this country, they are as well covered from their companies, but they have the basic insurance.
Okay.
Basic insurance, when I say basic insurance, it means that in emergency cases, they are fully covered. Fully covered. Regardless whether they have insurance or not, he can go to the best hospitals in the Emirate and he will be completely treated until the emergency will be over. Otherwise, if it's not an emergency, there are clinics which are designed for these, category of people where they can get the best treatment in addition to their medication. So if you think of it, in more spectrum, that everybody living in this country is having his health insurance, and that's why the health insurance is supporting. And slowly, as your colleague mentioned as well, that the government now is sharing the whole expenses of the health services on the private field. The private field, with the time, it will be one of the most important pillar in carrying the cost of the health services. This is actually I wanted to share with you that, really, the one who wants to establish any health insurance, he should look to the experience of the United Arab Emirates and how they did that.
Thank you so much for sharing that, and I believe that is the place we should be going to, especially in Africa.
Thank you, Doctor, for your opinion. It's very useful.
So much.
I think, as what Doctor said, the thing is, you do not want a patient to go to the hospital, especially a hospital that requires to improve with resources, to worry about the finance. You want the doctor to treat the patient and focus on the patient, that's all. If the patient required to worry about out-of-pocket system, then I think it's going to cloud their mind to decide whether they should go further and escalate the standard treatment of care. I think these are the challenges that face in developing countries when you're in the transition period, and a lot of countries are trying to look into a sustainable fund that is either governed by UAE side will be under the federal component, under the government side, or in our side will be on the private setting. So I think insurance or the pool fund concept might be one of the solutions that we can look into in your setting.
Yes, thank you, Dr. Kenny. On that note, I would like to end this this conversation, and thank you for joining us after the lunch, which is really very difficult.
Thank you very much, gentlemen,
Thanks, Alejandra.
on your talk on the underserved population. Thank you.